What I'd like to do is just show a little bit different way of doing the lips. It's essentially the same thing that you've done, but doing it a little different from the standpoint of trying to teach it to another doctor. And one of the things I do is I always think of how a new person injects. And they inject usually with a bolus and when they first start. So this bolus to me always looks like a Q-tip. They end up with this bunch of filler, and then it tapers out as they come out. And I like that for lips because, open for me a little bit, I always think of the lips, particularly the lower lip, I like them to start injecting in the lower lip because it gives us a little bit more leeway because there's not as many angles. So I actually like them to have a little bolus initially and then taper out. So because I know they're going to have that little bolus, I think of the lower lip as in two segments right at the midline. So I actually have them come in and inject between the wet and dry line, as we all know, and go right to the midline and inject and slowly taper out. And as they do that, they end up with this little bolus that gives them that little poofy area that we like to see, the little pillow effect in the middle, just naturally, just from the fact that when they inject, they get that little bolus, and then they taper out as they come out. And then the key, too, is that when they do this, I always have them lay the needle right down on the lip so you get that exact angle. So I make them position themselves to where the needle is laying on the lip in the same angle of the lip. So they go in to the midline, inject with that little bolus, and taper as they come back out. Again, not watching how much they put in, as we know, but from the syringe, but how much volume they're actually seeing the lip fill. And then I have them change their angle again, coming back, and so coming at from a kind of a more acute angle back further, going just in front of where they injected before, give that little bolus again, because it'll be a little bit more fuller here, and then taper as they come out. And they can blend those two areas quite easily by massaging it. So essentially, with a standard lip, they've only gone in 2 times, and they can massage it. If they have to, they can come back a little further if it's a fairly long lip. But by doing that, they immediately see that big poof in the center, and they can kind of push it up into that little seagull area that we talk about, and they know if they've got enough volume. And then we have them continue on the other side, same thing, coming to the midline, giving that initial bolus that they give naturally, then tapering back, then go back again, and come in to just before they've injected again. Give that little bolus, again, looking like the Q-tip, and come back out and just massage them together. It'll naturally give them that little poof they like in the front lip that's kind of like that pillow that fits up into those little areas of the seagull that we talk about. And it's a pretty straightforward, simple injection where they've essentially gone in 4 times and they've got it. Now the upper lip is a little more complicated, and that's why I have them do the lower lip first. But it's still the same concept of when they inject, they're going to give that little bolus first. So I have them inject not down in this area. I want them to inject here where we need more of the bolus typically. And again, it's just like we always do between the wet and dry angle, coming in, going up to the philtrum, stopping right at the philtrum, giving that little bolus. Go ahead and open for me again. And then tapering back out again. Now if they have a real high little seagull area here, then you taper a little bit more so you maintain that so they occlude in with that lower lip. So they would just taper out more if they have that. A lot of patients don't seem to have that, particularly when they get older in their late 60s and stuff. Stop that. All right, quit smiling. All right. So a lot of patients, as they get more mature, they don't have that little seagull area there. So what you would do is you would continue. Okay. So again, in the seagull area, you would just continue beyond that and just decrease the amount as you taper back. Again, it's critical that you watch the angle. You don't come in straight. You lay the needle on the lip and maintain that angle that you're putting the fill in. Just putting the volume in, not doing anything with a vermilion border at all, just that initial body for a level 1 trainee. So again, then you would come down into here, and with the length of the needle going up just past where you initially did the injection. Again, you get that initial bolus, and then you taper as you come back out. So it's 2 sites in this, simply tapering as you come back out, and you can mold these 2 areas together. And by following that natural initial bolus, it makes a really nice lip through here. Now, one of the problems that I see, depending on the patient selection, when we have a younger patient, you really don't need to go in here in this area to treat the Cupid's bow. But sometimes what happens is we get these older patients that the doctors bring, and if you just treat the volume here and you treat nothing in this area here, then it looks deflated. So in that case, what I do is something very similar to the vectors, but it's a very simple thing, because by this point, they've already done the lower lip, they've already done the lateral aspects of the lip, and now we want to do this little area here where they need a little bit more control. But again, with this technique, it takes advantage of the fact that they're going to give a little bolus. So simply what they do is they come in at that peak of the philtrum, because we want to maintain that peak. They go in and they go right to the midline, right to where you have the most volume right here. And what you do is you would just give that little bit of filler so they get an initial bolus, and then you come right out quickly and a small, smooth taper. And again, the same thing, angulation is critical. You have them go in at the philtrum, you lay that needle on the lip right at the midline, so you get your angle just perfect. You come into the philtrum. Again, they naturally give this little bolus and then they taper out. And that maintains that nice little Cupid's bow. The other thing that if I see that if they don't have this philtrum at all, but you can see where it was, it's very easy to go in and treat those. We've taught them how to do linear lines. So it's a nice, easy linear line for them to do, to go up into the philtrum, following the angle again of what the philtrum looks like, and go in and give a slight injection, come straight out, again, straight out, and then just form it with a Q-tip on each side or a tongue depressor, and it gets that philtrum back and gives that nice tone back to that upper lip. So it's a simple technique for a level 1 person. They can get a nice lip without dealing with vermilion borders, and it gives them a set parameter in which to start.